Okay, so let me do the welcome for everybody.
Yep.
Good evening and welcome everyone to part 2 of the piezo surgery webinar by our beloved Dr. Angelo. We saw last week the advantages and the effectivity of piezo surgery over conventional methods. And we saw a few cases where, especially that episectomy case was, I think for me, it was like an eye-opener. Although I've been using piezo myself for several years, but the kind of results that we get and the healing was fantastic. Today is the part 2, more geared towards implant dentistry. We're going to be talking about the intralift, the internal sinus lift, that is, crest split, maybe nerve repositioning, and a couple of other indications like subperiosteal tunneling. And I will not waste much more time, and I will hand you over to our guest for tonight, and our professor, Dr. Angelo-Piezo, and he will take the stage for me. Welcome, Angelo.
Thank you, dear Ashish. And I thank you even more since you are back again after your birthday and after your what happened. Yeah. So thank you very much for the introduction, and we'll go right into the matter. Today I will try to stick in time. So if I get too long, Ashish, please give me some hint that I maybe overdo.
Yeah, we may be hit by the storm before we give any hints. So you can update the participants accordingly.
So this is why before we start to go right into the matter, I just want to warn you, because right now a big thunderstorm is approaching Austria and especially my region where I live in. And we had the experience last week because we had disastrous thunderstorms with hail like apples in of the size. So if suddenly I vanish from your screens, please, I have to apologize. Then I was a victim of the climate change, because thunderstorms get really, really terribly heavy here. So if I'm offline, that means we have a blackout, no internet working for the time being. So of course, then with Ashish, I will make up a date for a repetition of this webinar. But let's go right into the matter. In a short summary of part 1, I just want to summarize what are the benefits of piezo surgery as the new gold standard in oral surgery compared to rotary instruments. So first of all, we have the minimized terminal bone necrosis, since of course rotary instruments have been the standard until now. Now it is replaced by piezo surgery, and terminal bone necrosis by heat dissipation you can achieve only if you do not adjust the cooling liquid, which has to be adjusted to a certain state, like 70 or 80 milliliters minimum per minute with piezotomes. Second of course, we know that with rotary instruments, we have a crushing of the surface, a destruction of the bone, like a big complicated fracture. Instead, with the piezotome, it's a simple, single, smooth osteotomy site comparable to a simple fracture of a long bone, for instance, which you just stabilize and it will heal within a short time of period. Bacterial contamination prevention, just imagine when you work with rotary instruments, the rinsing solution is spilled all over the place, into your face, into your assistant's face, into the air of the surgery room. Contrary, I've been demonstrating this last week with the piezotome, due to the modulation of the oscillation, the liquid adheres to the surface of the tip. It's not spilled apart, it's sticking to the surface by the oscillation and resonance phenomenon. So you will have a very clean visor with your surgery, and you don't have to fear bacterial contamination of the patient's rest of the oral cavity and or your assistant and yourself. Improved bone healing. I was showing the histology last week. The basis is that by using the piezotome, You have a 3-time higher osteoblast activity in the healing site when you use piezotomes. High precision bone cut design, I will repeat to show you when we get to the end of the webinar, because only with piezotomes you can carve your initials or letters into bone. Almost lossless bone cut. We know the procedural bone loss with piezotomes, which we absolutely do not have with piezotomes. Precise depth control. That means when you're working very close to diligent structures like mandibular nerve or sinus membrane, then with the piezotome, you have a much better depth control than with rotary instruments. Prevention of soft tissue injuries. Just remember the demonstration on the sheep head, where with the same frequency and with the same adjustments, we cut bone, then move the tip, which is a very spiky tip, on top of the sclera of the eye, and no lesion of the sclera of the eye takes place due to the cavitation effect. And then, of course, the significant reduction of post-surgical patient morbidity, which I will today also present in some clinical randomized clinical studies regarding some bone augmentation procedures. Once again, we have here the references regarding the superior soft tissue preservation in comparison to burst drills and lasers. These are the most important ones. You can look it up when you go to our homepage, and then you go to Dr. Google. Maybe you get them for free, or you get them from your university access to Medline. Then references regarding superior bone healing compared to use of rotary and slow oscillatory instruments. And last but not least, independent replications and verifications of our own research work regarding morbidity after piezotome surgery, clinical studies regarding soft tissue preservation and safety, and replications and verifications of basic experimental studies regarding bone healing. So far as a summary. Now to step right in, we start with a, let's say, simple case, although there are not simple cases in oral surgery. Even a simple tooth extraction can turn out to be very, very difficult due to ankylosis of the root. So whatever surgery you do, take it seriously. In this case, we have the case of a palatal impacted canine, and the task is, of course, to remove the milk tooth, the milk canine, and to preserve the bone as best as possible, to install the implant possibly simultaneously, which with rotary instruments in, let's say, 90% of the cases won't be possible, because you can see here with a so-called bone scraper, you just remove the very, very surface of the bone so that you get access to the crown of the impacted canine. Now, instead of removing the bone all around the impacted canine, we do a coronectomy with the so-called ninja tip. It's one of the more aggressive tips, and it's also a tip which you are not supposed to use in the vicinity of the mandibular nerve or the Schneiderian membrane. Why? Because due to the oscillation pattern and due to the very, very spiky surface and the high energy it produces, there could be a slight risk of harming soft tissues. So the crown was already removed. Then you can take out the rest of the impacted tooth. And what you can see here is there is no bone loss. The only bone lost was the surface that was covering the crown of the root. Unfortunately, due to the length of the video, I had to shorten it a little bit. You can imagine we saw this already last week with the tip, with the ligament cutter tip. Of course, we cut the periodontal ligament. And then, of course, as you have seen, it was possible to take out the apex of the root, the rest of the root with a simple forceps. Then you can install the implant immediately, because 90% of the implant is in solid bone. The rest of the alveolar, of the impacted canine, you can fill with bone graft material, and that's then the post-surgical X-ray with the installed implant, which makes, of course, the whole procedure Mostly we're speaking about younger people. In this case, they don't want to stay too long without the canine for their beautiful smile, or with a small prosthesis or an intermediate bridge or whatsoever. So the whole procedure is shortened down to 3 months up to 4 months, when you can install then the crown. In case the bone quality in the maxilla is very high and your implant system has a very high primary stability, it could be that you could even install an immediate loaded implant with a provisional crown. In this case, due to the, let's say, not so good bone quality, it was a D3, D4 bone quality, we went for a 2-stage surgery. So there was a question at last webinar: how can we use piezodome in orthodontic applications? For this, of course, piezodomes are an absolute must in any kind of orthodontic surgical procedure, of orthognathic surgical procedure. But for the practitioner in his own office, the most interesting part will be, of course, the piezocision, the monocortical osteotomy, to make tooth movements more precise and more fast and more predictable. For this, there is a completely different protocol to the traditional protocols, which is just simply making a mucoperiosteal incision without raising even a small tunnel or something like this, and then a direct cut with special tips developed by Professor Dibar from France. And of course, according to the anatomical situation, we also use templates, osteotomy templates for the guidance, especially in crowded and angulated root position. But as you can see, it's just a simple incision and then just simply doing the monocortical osteotomy. Nevertheless, we use, of course, piezodome surgery exclusively also in orthognathic surgery, like single tooth osteotomies, or even better, in single implant osteotomies. You might already have seen a lot of cases where implants in the upper front were misplaced with a too high angulation to the palatal side, so that the need for a very angulated abutment would have been necessary, or a cosmetic perfect restoration wouldn't have been possible with a misangulated implant. So in this case, instead of removing the implant, doing bone augmentation, you just cut out the implant together with the surrounding bone, like transferring an autologous bone block graft. You readjust it in the correct position, and then you let it heal for another 3 to 4 months. And then you can, of course, use a straight abutment and do a cosmetic perfect crown. Next, the 4-1 osteotomies, much more precise with the piezodome. Of course, you can imagine to follow the apexes of the roots with rotary instruments or even slow oscillating saws is almost impossible. Here you can precisely design whether you have to reduce the bone height or you have to readjust in the mesiodistal aspect. Whatever you do, you can mark your incision lines and your bone removal lines before you start the osteotomy according to your planning in 3D on the bone, and then you cut at the utmost precision so that the readjustment of the segment is much more perfect. You have direct contact of the bone, and by this, of course, a much faster bone healing. Then bond osteotomy, mandibular front distraction, cheekbone osteotomy. We do a lot in cosmetic surgery with the piezodome. With this perfection, with rotary instruments, you can imagine, since you are engulfed by a lot of soft tissue, you have the side effect that with rotary instruments, of course, you're going to smash all the soft tissue with the result of very, very heavy swellings and sometimes distortions of and scary healing of the soft tissues. Of course, with the piezodome, since it's 100% soft tissue safe, you don't have to await much more precise results. And last but not least, TMJ surgery, and of course bone grafting from skull if you need a lot bone grafting, like for instance, reconstructive surgery after tumor surgery, then of course the piezotome is the instrument of choice. But let's take a look on how the traditional way of the monocortical osteotomy was performed and how it is done according to the development by Professor Dibar from France. So to enhance the movement and to make two-teeth orthodontic teeth movements more precise, right away until now, it was especially done in the United States, you had to raise a full thickness mucoperiosteal flap. I mean, just imagine how devastating it is simply to raise a mucoperiosteal flap. What does raising a mucoperiosteal flap mean, especially if you're not using the piezotome? It means that you disrupt the osteogenic layer of the periosteum that's containing the osteogenic cells, the only osteogenic cells that lead to the mineralization of the bone. You completely interrupt the nutrition of the bone. That means only by raising a full thickness mucoperiosteal flap and by interrupting the nutrition of the bone, you are going to have procedural bone resorptions since the bone is not nurtured and not vascularized anymore. Then, of course, also the cosmetic side effects. You have to do this the entire maxilla or mandible. Then you do the very, very dangerous monocortical osteotomies with rotary instruments, and especially when the roots are angulated at the apex towards each other, or if you have an interposition of a root, with rotary instruments, you can't be that precise not to risk a lesion of the periodontal ligament or even opening the root canal if you get into the dentin. So this is why this method I did once during my education some 35 years ago, but I never ever did it to my patients when I do orthodontic treatment, especially when we do let's say, the most advanced orthodontic treatment with Invisalign. Contrary, when we use the piezocision, you can see here how you can handle a case like this. You just simply do mucoperiosteal incisions according to your planning based on a CBCT scan. In case there is a more complicated situation regarding, let's say, the angulation or the nearness of the roots to each other, there is a advanced procedure with the piezotome, which is described by Hu et alia, by Milano et alia, which is computer guided. So you can also create a template where through the template you do the incisions, and then of course you use this tip developed by Professor Dibar to do the monocortical osteotomy. And with the template there is, let's say, the risk to interfere with the periodontal ligament is approximately 0.1%. I mean, you really have to be very crude and misangulate it. Of course, these tips you can have in different angulations because due to the anatomical situation, of course, and due to the approach to the site, you sometimes need the angulated versions. And they do exactly their job. And these are just some of the references that prove that this method is far advanced to the old traditional way with raising big mucoperiosteal flaps. And what is also important, let's say from the economical standpoint, this procedure, the old one, which I would say shouldn't even be done because it's so devastating to the bone nutrition. In this case, of course, you almost, in most cases, you don't even need any suture because you just made a mucoperiosteal incision. You didn't raise a mucoperiosteal flap. So just by a little bit of bleeding, the margins of the wound will be welded together by the hematoma, which is quite sticky, and the bleeding stops after about half an hour, and you don't even need sutures. And of course, there is no swelling after the procedure, no pain after this procedure, and of course, the orthodontic treatment, especially in combination with Invisalign, but also with traditional methods, is speeded up by 1/3, and especially rotations of lower molars or upper molars with 3 anchored roots and the canines The rotation, we know it's quite a difficult movement. They go much more precise when you do the monocortical osteotomy with piezotomes. But of course, you can read all the publications by Professor DeBar and by Dr. Kesa. She's the co-inventor of the piezocision tip set. And you will see in clinical studies, in randomized clinical studies, that is really a major step towards a more predictive orthodontic therapy in difficult cases. Now, let's get to guided bone regeneration, let's say the next level in implantology, because what we are mostly lacking in implantology is, of course, we are lacking bone. So what do we need, or how can we use the piezotome to do so? First of all, of course, we use it in vertical alveolar crest splitting. Then we use it for lateral approach sinus lifting and the intralift method, the subperiosteal tunnel technique, the mandibular nerve transposition, distraction and sandwich osteotomy, and of course, bone block grafting. So to start with the subperiosteal tunnel technique, because it's very similar to the demonstration on the histological level I showed you. And in this case, I show you a photo of the biomaterial experts group, of which Professor Ashish Kakar is, let's say, the most important part. And in this place, forgive me, dear Ashish, once again, happy birthday to you. His birthday was on Monday.
It was Monday. It's 363 days to go now, so don't worry about it.
Yeah. And you can see here now, Professor Kakar already published in 2018 a breakthrough paper regarding the subperiosteal tunnel technique. And what you can see here, this is the International Biomaterial Experts Group, biomaterial experts from all over the world, North America, Germany, and of course, leading part, India, Spain, Latin America, etc., etc. So just to give an impression, who are the faces behind these groups that develop new bone graft materials and new bone regeneration procedures. So what does the piezotome enhanced subperiosteal tunnel technique mean? I give you a clinical case. This is the typical case where we have a bridge from upper right canine to left upper canine. And here we have an absolute lateral atrophy of the maxillary bone down to 1 millimeter up to the nasal floor. In this case, we just make a mucoperiosteal incision distal of the augmentation site so that there is no need to push in some bone graft material or to make the sutures of a bone graft material. Always, this is a general guideline when you prepare mucoperiosteal flaps, the margins of the mucoperiosteal flap should always rest on solid, untouched bone, never open in a way that they are over a hollow space or they are just on the rest of the augmentation material. Then, of course, we raise the mucoperiosteal flap with the piezotome. As you can see here, you have seen the photo already last time. This is how a perfect mucoperiosteal flap should be raised, because this layer, the osteogenic layer, is the only organ in the entire body that contains the osteoprogenitor cells, the pre-osteoblasts that migrate for the proper regeneration and mineralization of the bone. So here you can see the tips we use. It's the BS4. Of course, still we have some experimental tips in work, which hopefully then will be issued by the next year. There we have a little bit of a delay due to the COVID pandemic, which is somehow an excuse for almost everything with the delay right now. Now you can see how the tunnel is raised. It's just a microscope, just a very, very small incision. And instead of raising a full thickness mucoperiosteal flap with an incision on top of the alveolar crest, it's just a tunnel. But basically, and this is so important to understand, not to put things into categories, a subperiosteal tunnel is a smaller, simple mucoperiosteal flap. The only difference is here you don't have to suture, and so this is where you have absolutely no risk of having a dehiscency in the healing period. Here you can see once again how perfect and clean the periosteum can be detached from the bone, which is only possible with piezotomes. Then you apply some self-hardening bone graft material. In this case, we used EasyGraft Crystal, which is a composition of beta-tricalcium phosphate and hydroxyapatite. Of course, nowadays we should always add PRF, platelet-rich fibrin. But once again, to make a long story short, what we used until now with bone graft material, also autologous bone, was mixing it with autonomous blood. On the other hand, if we look at PRF, it's just the same autologous blood of the patient, excluding the erythrocytes. And by the centrifuge principle and by the centrifuge protocol, it is enriched with bone morphing protein, leukocytes, etc., etc. That's the only difference between the natural blood clot and PRF. And since the PRF is a concentrated, enhanced blood clot, of course, we achieve better results. Just a sentence aside to make once again things clear. Here you can see now the final result of the surgery. There were just 3 stitches. And of course, now here nicely, we have the bulging out of the situation. Here you can see the post-surgical CBCT scan. This is the old outline of the alveolar crest. It stops here. And this is what we achieved with this case with this self-hardening bone graft material. So the net effect of this lateral appositional method is accumulated 6.1 millimeters, which is absolutely sufficient for implant insertion. Now, in the second stage, after a healing period, always remember, I will repeat this also with the intraleaf procedure, the bigger the volume of the augmentation, you longer have to wait. In this case, we used approximately 1.2 cubic centimeters of bone graft material. So in this case, per each 0.5 milliliter of bone graft material, you have to wait approximately 3 months until it is fully regenerated and also integrated into the newly formed bone. So in this case, we inserted the implants 6 months after the initial surgery. And you can see here now how perfect this bone was regenerated. I mean, in this case, it was so good also due to the biomechanical properties of the EasyGraft material. Since it's containing 60% hydroxyapatite, it was so highly stable that we were able to insert immediate loaded implants. The benefit for the patient was 2 minimal invasive surgeries, and at no single time of his treatment, he had to wear a removable overdenture or some kind of provisional removable provisional prosthetic treatment. So he just went in with his old bridge. He went out after 6 months with his new implants. And of course, his prosthetic doctor then did the prosthetic treatment the same day when we inserted the implants. So these are some of the results. We have to do a lot of times in the upper front. We have to do a lot of times the horizontal augmentation with the subperostal tunnel technique, because this is most prone to horizontal atrophy. Here you can see some results after inserting the bone graft material, and here is a long-term patient who received his subperostal tunnel technique already some 12 years ago. The implant is inside. Also in this case, we were able to insert single-stage implant, and you see how nice and stable and how voluminous, especially on the buccal side, the subperostal tunnel technique acts. And just to give you an idea, you see this is the structure of the patient's own bone. And this is a mixture of hydroxyapatite. It's also EasyGraft. You see, it's much more dense than this type, the autologous bone, which means a higher biomechanical stability. But this is, let's say, content of a different lecture. Maybe Professor Ashish can hold for you. So now we get to the flapless piezotome enhanced crest split and widening technique. You will very soon also receive from Professor Kakar maybe a copy of his own publication regarding this. So I'm referring now right to our own research work, which was presented at the EAO Congress back in 2018 in Vienna, and which was published in the Clinical Oral Implants Research Journal. So the question is now, the traditional reconstruction of the alveolar crest width is, of course, autologous bone block transfer. First of all, with rotary instruments, we discussed this already at the last webinar part, is that we destroy a lot of bone when we take out the autologous bone blocks with rotary instruments. Of course, nowadays, autologous bone block transfer, the absolute undeniable gold standard is piezotomes. But nevertheless, what we know from the traditional autologous bone block onlay grafts, we know that the bone loss, the horizontal bone loss after lateral bone block augmentation in all reviews and meta studies is approximately 25%. That means 25% of what you achieved with the onlay graft, you are losing in the course of healing. And the average net width gain is only of the onlay graft is 3.9 millimeter. This could be insufficient later on for an implant insertion. And of course, you can imagine when you do a surgery like this, you need a lot of bone. So in this case, of course, we needed to take the bone from the chin and of course from the lateral side of the mandible. And this is all we can get. There is nothing left over to take bone off. So if we would have needed more, no way to get it. So of course, we have to look for an alternative. In some cases, you will still need autologous bone block grafting, but in most cases, especially in lateral atrophy, you can replace autologous bone block grafting completely by alveolar crest splitting. So when we did the clinical study, our hypothesis was that we can achieve comparable results. You see the typical surgical procedure of the flapless piezotome enhanced crest split, just a mucoperiosteal incision, vertical osteotomy, vertical widening, buccal relief osteotomies, insertion of implants, placing bone graft, suturing, and mostly after 3 to 3.5 months, the loading of the implants. So in our study, we investigated 533 patients, which we treated with a piezotome crest split, and the control group was 531 patients. So this is, let's say, a sufficient number to get a valid statistics. So how does our development work specifically? First of all, when you start with this surgical technique, you strictly have to follow the protocol, as you should always do with the technology or with the technique you use the first time. So the first step is always do a mucoperiosteal incision on top of the alveolar crest, then do the vertical mesiodistal osteotomy, minimum 8 millimeters. So in your first cases, you should have at least 12 millimeter vertical alveolar crest height over the mandibular nerve, because you need additional 3 millimeters for the implant insertion, for primary stable implant insertion, and then of course in the mandible as a safety space to the mandibular nerve, let's say at least 1 millimeter. So stick to the protocol. Story starts at the beginning when you start with this procedure with 12 millimeters minimum alveolar crest height. Once you did 10, 15, 20 surgeries, of course, then you can do variations. And what you cannot abort in any way is the buccal relief osteotomies. That means you have to do on the mesial and on the distal end a buccal relief osteotomy. And then you slowly do the widening with the provided tips in our tip set, and then you can insert the implants, and in the intermediate space, you can place the bone graft material. So please stick to the protocol when you start your surgeries the first time. Here is a case from the upper jaw. You can see here now on the left side, the alveolar crest has a width of approximately 1.5 to 2 millimeters, and this is then, you don't prepare a mucoperiosteal flap, you just open a booklet flap so that you can access precisely the top of the alveolar crest. You do the buccal relief osteotomies, then you push in the bone graft material and you close. This is a case for a two-stage surgery where no simultaneous implant insertion was performed. Since in our clinical studies, we wanted to compare directly autologous bone block transfer, which 99% is done without simultaneous implant insertion with the crest split technique. And here you can see the right side of the surgical site. It's a little bit wider. Same procedure. The alveolar crest width was only 1 millimeter. So that tells you that with the piezotome crest split, you can even split 1 millimeter wide or narrow alveolar crests, but to two slices completely connected to the nurturing periosteum to 0.5 millimeter halves that you squeeze apart. The bone graft is then inserted, and then, of course, you do the sutures. And in this case, the healing period would be around 5 to 6 months. You can see now a CBCT control of this case. The first initial width was 1.2 millimeter on the same space after doing the distraction and before filling the bone graft materials, we achieved 6.7 millimeters. Of course, we cannot make wonders. Even piezotome surgery cannot make wonders. But remember how much with the autologous bone block graft in average you are going to lose on width. In this case, we just lost exactly 1 millimeter in the course of healing, but you see nice cortical bone and nice dense bone to insert the implants. So what were the results of this study? Let's now focus also one of the critics of piezotome surgery, that it might take so long. Actually, that's not true, and especially with the crest split, because you spare all the time to remove the autologous bone blocks. With the onlay graft, the average surgery time was 90 minutes. With the crest split, approximately 40 minutes. So, of course, you spare a lot of time, and the alveolar ridge width was always better with piezotomes, but honestly, it was not significantly better. So the pre-surgical situation, post-surgical situation immediately after the surgery, and then in average, we had a loss of 0.2 millimeters in width in our own study. Remember, the meta-analysis of a lot of clinical studies tells us we lose 25%. In our study with the onlay graft, we just lost approximately 0.5 millimeter, with the piezotome only 0.2 millimeters of bone width. And of course, and this is also always the same story I told you already at the intro of this webinar part, whenever we investigate how much pain and swelling does the patient have when he undergoes a surgery with rotary instruments or with piezotome surgical instruments, you see a reduction of almost 50 or more than 50% in the entire healing period from day 1 after surgery to 2 weeks after surgery. So what is the evidence of this clinical trial? Flapless piezotome crest split is a significant less traumatic alternative to buccal onlay grafting with autologous bone blocks. And this is now based on a type 1 randomized clinical trial, which is the highest evidence. The flapless piezotome crest split achieves better results regarding final horizontal alveolar crest width, not significantly better, but definitely always better than with autologous bone block grafting. And flapless piezotome crest split provides significant less surgery time consumption and post-surgical morbidity. I showed you already this in the last slide. So, of course, you always have to keep in mind that in the course of healing, since we have to open a small booklet flap, we have to await also a vertical bone loss, since we interrupt slightly the nutrition of the bone, not as much as we do with autologous bone block grafting, but we interrupt it slightly. So we also made an investigation which was published back in it was in 2015, where we investigated the more wider cases with 2 or 3 millimeter remaining alveolar crest width with only the extreme cases of 1 millimeter. So the maximum of vertical bone loss is approximately 1 millimeter. So our advice is, if you then later on start these extreme cases, of course, insert the implants slightly subcrestal to compensate for the vertical bone loss in the course of bone healing. Here is such a typical case we have 12 millimeter alveolar crest height above the mandibular nerve. Here you see once again the surgical procedure, mesiodistal mucoperiosteal incision, initial widening, then buccal relief osteotomies, which you absolutely should not abandon. You should always do it, otherwise you might occur some accidental iatrogenic fractures somewhere else. Then you do the widening, then insert the implants, in most cases immediately, fill the gap with some bone graft, especially self-hardening bone graft material, do a wound closure, and then after 3.5 months, you can do the prosthetic treatment. And the patient won't have any pain and any swelling, since it's less invasive than a tooth extraction with rotary instruments. Here is the situation immediately after surgery. Here is then the situation after prosthetic treatment, 3.5 months later. You can see in this case, no vertical bone loss. This is the situation after 1 year, after 5 years, and now after 9 years. And you see in this case, we didn't see any vertical alveolar crest height bone loss, but this is, let's say, the case that, of course, is always presented in webinars and in lectures, but always keep in mind, you might lose 1 millimeter crest height. So insert the implants subcrestally. Here is another case. It's 1.52 millimeters. And later on, this is one of the cases of the study. Here you can see now, when the implants are inserted, they are always right in the center of the distraction site. Now, let's get to sinus lifting, which of course is also of high interest. And I don't now refer to the lateral approach sinus lift, because let's say we are somehow a little bit critical in time. But for this, I can advise you to visit our homepage. I will give you the internet link at the end, and you can see all the nice videos by Dr. Gerasimov from St. Petersburg, who has a lot of video material presenting the piezotome-assisted lateral sinus lift approach. Today, we are going to speak about development by my research group. It's the intralift procedure. Of course, first we have to ask ourselves the question, in the age of short implants, can we do without sinus lifting? The answer for at least, let's say, Caucasian people is definitely no, because in a Caucasian population, because this was an investigation performed by some of my postdocs on more than 3,528 measure points, that 2/3 or more than half of the patient cannot even be treated with short implants, because when we speak about short implants, I speak about 6 millimeter long implants in the first molar region of the maxilla. If we speak about 4 millimeter, then we could discuss if at least 1/3 or 1/4 of our patients cannot be treated without sinus lifting. And here you can see the measure distribution in the cases of this study. So how does now the transcrestal sinus lift work? Very simple. You might have heard, or you might remember, depending on how long you are already active in your profession, that there was something called the balloon-assisted sinus lift. So balloon-assisted sinus lift was creating a transcrestal approach, pushing in a balloon, blowing up the balloon, and with the balloon distracting or detaching the sinus membrane from the bony floor. The very basis for this, because it was a hype back in 2004, 2005, but we in our research group, we always asked ourselves, but why? Why do we need a balloon? We can do this without a balloon, and this is the basic principle of the intralift. With a diamond-coated tip for even more soft tissue safety, we open the sinus floor. Then we prepare with a special diamond-coated tip a ventral seat, which is slightly smaller than the final tip, which we have to insert. It press fits into the transcrestal approach. And then simply by building up water pressure, hydrodynamic water pressure, accompanied by the cavitation effect I explained in the first part of the webinar, we detach the sinus membrane from the sinus floor. And due to the precise protocol, which you have to stick perfectly by all means, this cannot be changed. You can then push in the bone graft material, either regarding to your implant system and regarding to the remaining alveolar crest height, you can simultaneously insert the implant or do a two-stage surgery. To show you how this works in real life, it's just a very, very small mucoperiosteal flap like this. You do the entire procedure through a 2.8 millimeter wide transcrestal approach, and that's the result after suturing. But what you can achieve with this is this. You can fill the entire sinus floor. This is the surgical access, here, here. This is the surgical access, and with this one single access, you can fill the entire sinus floor, the entire sinus floor. And this is the big advantage of the intralift. Absolute minimal invasive with the same result as you can achieve with lateral approach sinus lifting. So let's take a look at the surgical protocol as an animation. As you can see here now, you just do a crestal flap, a mini booklet flap like you do with the crest split technique. Then with the diamond-coated tip, you do some kind of pilot drilling. Of course, it's not a drilling because no bone is getting lost. The bone is condensed, which gives a higher stability than to an implant, especially when you simultaneously insert the implant. Then with this diamond-coated half-round shaped tip, you open the sinus floor, you feel a slight resistance. And remember, piezotome surgery is soft tissue safe. That means if you do it correctly, there is no chance that you might cause a perforation. Only if you push very hard, of course, then even with the tip like this, you will be able to perforate the sinus membrane. And now comes the critical part. This has to be pressed into the ventral seat, and then simply by pushing in the hydrodynamic pressure together with the cavitation effect, you can raise the sinus membrane from the entire sinus floor. Then, of course, depending on if you decide to insert an implant simultaneously or not, to be a little bit more fast with pushing in the bone graft material, you can widen the access to 3 millimeters, then push in the bone graft material and the implant, or only the bone graft material. It always depends on the remaining alveolar crest height and not on the surgical procedure intralift. Okay, I will make this story shorter. So this is the clinical case. This is the situation before. This is the situation after. And you will always see, due to simple physics, the implant with an intralift procedure will always be exactly in the center of the augmentation site. In this case, we did a simultaneous implant insertion. Here you can see how this works out in real life. You see also this nice feature, there is almost no bleeding. There is not a lot of action. So subjectively to you, it might seem, oh, it's taking so long. Actually, it's not taking so long. It takes about 1 minute to open the sinus floor, especially in cases where the remaining alveolar crest height is only 2 or 3 millimeters, in this case, 3 millimeters. Now we are preparing the ventral seat. This we do without any movement and just deep enough so that we can snug fit the trumpet or the TKW5 tip. And now you can see this is where the water comes out. And of course, the tip is a little bit wider than the tip we prepared the ventral seat before. And this is now when the action starts. So you press it onto the site, you count for 5 or 6 seconds. And then what you can see is all the water you pump between the sinus membrane and the bony floor flows back. No gas bubbles. That means you have total control over the not perforating the sinus membrane, and you also have visual control. You just take a mirror, you make the Valsalva test, and when the patient inhales, you see how the sinus membrane flows back into the sinus cavity, and when the patient exhales, the membrane is floating back. So you have still very good control over the surgical procedure. Of course, you have not just a wide view like with the lateral approach sinus lifting technique. What is time consuming, I have to admit, is we have only a very, very small little hole. And through this hole, we have to place enormous amounts of bone graft. So we cannot just take a shovel or we take the ampulla of the bone graft material and pour it in like we sometimes in the lateral approach sinus lift. No, we have to do it step by step. You might have asked yourself, why do we need such a big mucoperiosteal flap in this case? We need it because in this case, we decided to do the implant insertion simultaneously. What is extremely important, don't ever think about doing all the drilling before and then only the last step you're doing will be the intralift. No, the only way how this could work is first you do the intralift, at best always in the first molar position. Why? Because if you have secondary holes, the water, the hydrodynamic pressure builds up here, but when it detaches here, all the water flows back through the already drilled hole. And that means that you will be never ever be able again to raise or to detach the sinus membrane. In this case, you need a flute player to close these holes with the fingers or with some other device, or maybe with some silicone plugs, so that you can then proceed with the intralift procedure. This is very important. Intralift, only one single transcrestal approach. To give you an idea how this is looking from the inside, now you see the same procedure from the inside. Once you start to pump or to add the hydrodynamic pressure and the cavitation effect, you have a detachment on the entire sinus floor. And when the pressure reaches the peak, plop, suddenly, and this is after 5 seconds, the entire sinus floor is raised. So you can do sinus elevation through one transcrestal approach for 3, 4, 5 implants, how many implants you want to place into the sinus floor. So now in slow motion, you can see how after the sinus membrane was elevated by the hydrodynamic pressure, how the water flows back again. Here you can see the Valsalva test in slow motion. Patient inhales, sinus membrane flows into the sinus cavity. Patient exhales, sinus membrane flows back again. This is minimal invasive surgery. Now to take a look at the, this is a different case. It's not the same case. It's where you can see the plugging of the bone graft material. In this case, no implant was inserted simultaneously. But it's so important. Here is the mesial part, which goes to the nasal cavity, because the endoscopic view we always have over the transnasal approach. So this is the distal side. This is the nasal side of the sinus. And you can see the entire sinus floor can be filled with the bone graft material by one single 2.8 millimeter transcrestal approach. This is then the final result. As I told you before, as I showed you before, implants are always exactly in the, sorry, here I was a little bit too fast. Implant is always exactly in the center of the augmentation with the intralift. It's a physical principle. Here you can see the patient's own bone. Here you can see the bone graft filling and the implants exactly centered in the center of the augmentation. Now, another clinical case, a typical case for the clinical routine, devastated periodontal situation, no way to insert implants without bone grafting or bone augmentation. In the first step, the loose parts of the bridges were removed, and during the removal of the tooth here, of the teeth here, and the bridge here, the intralift was done simultaneously in one session. So this is then the situation 6 months after intralift. You see this typical dome shape when the implants were inserted. This is then 9 months after the intralift procedure. where the implants are already uncovered and the abutments were adjusted. The rest of the teeth were removed and another single stage implant was inserted here. Remember, we have here the intralift, which we were able to extend to the canine region. So a very, very long primary stable implant was able to be inserted. And here is now the situation, to make a long story short, the situation 11 years after the intralift with some additional implants down here. Here is the original situation after removal of the bridges and after intralift. And this is then the result 11 years. Quite stable. And of course, the patient has to undergo a regular periodontal treatment to, as you can see here in the lower jaw, the patient lost his teeth due to heavy periodontitis, due to insufficient cleaning. And of course, we always have to prevent that the patient is going to lose the implants due to improper oral hygiene. So the results of a randomized clinical study compared lateral approach sinus lift with intralift. The number of membrane perforations is 1/3, 2/3 less with the intralift than compared with the lateral approach sinus lift. Aborted procedures was half as much as we had to abort with the lateral approach sinus lift, and the osteotomy time, of course, was faster with the intralift procedure than with the lateral approach sinus lift. The achieved augmentation height were slightly better with the lateral approach, but not significantly. So we see the average volume is here 12.9 compared to 12.4 with the intralift procedure. But of course, morbidity, once again, rotary lateral approach compared to piezodome surgery, more than 50% less pain and swelling with the piezodome assisted procedure. Now we already get almost to an end, still 5 minutes to go. So I want to show you, last but not least, also another and very, very helpful surgical procedure that is able to reduce the pain and the morbidity of the patient and enables you for a faster and more predictable result. We speak about the inferior alveolar nerve lateralization. Just to give you a first overview, it's a typical case. Here we have the inferior alveolar nerve, absolute atrophy of the alveolar crest, no way to insert implants, even not for in the interforaminal area to just make a removable overdenture bar retained. So in this case, of course, most patients want to have fixed prosthetic treatment. So what you do here is you do the horizontal osteotomies on top of the alveolar nerve. This is exactly the section here. You do with a saw, which is quite fast. But the vertical osteotomies you do with the diamond-coated tip from the sinus lift tip set for the lateral approach sinus lift, because even if you touch with the sinus lift diamond-coated tip over a longer time of period, the mandibular nerve, it will not be harmed. Once you see the mandibular nerve, you can remove with the diamond-coated ball type tip the possible spikes from the sponges bone, and then you just carefully lateralize or get grip on the mandibular nerve. You lateralize it, you install the implants, you place some collagenous tissue over there, or autologous connective tissue graft or synthetic collagenous cushions, so that the nerve doesn't press on the implant, which might give irritations to the nerve. And what you can see here, this is the situation some 1 year after the surgery, and there is always the formation of a new mandibular canal more lateral to the implant. Now, another case in more detail. Here you can see how we should proceed with the typical situation. So we have a vertical atrophy of the alveolar crest, no way to insert implants. So what we do is we do the horizontal cuts with the BS1 saw and the more wider cut with the SL1 tip from the sinus lift tip set. You can see these are the tips for the horizontal osteotomy, diamond-coated tip for the vertical osteotomy. Then we have to dissect this bone into a mesial half and a distal half because, of course, the mandibular nerve, the mental nerve, runs through this hole in the bone. So we have to separate these parts. Depending where you want to install the implants, of course, you can also do the vertical osteotomy distal of the mental nerve. This is just a case where we needed to act like this. It always depends on the exact location of the implants you want to place into the individual patient's situation. Then, of course, you have to stabilize and you have to protect the lateralized mandibular nerve because now you're coming with the drills for inserting the implants. So you can buy either extremely expensive vessel loops from a hospital supplier, or you just take a sterile glove like you see here. You cut off a stripe of the sterile glove. And this, I always do it like this way after I found out when a friend told me, because this is much wider than the vessel loop, so you can cover the entire length of the nerve with one single strap of the sterile glove, which is also much cheaper. Then you install the implants. You always have to take care that your assistant who holds the nerve apart does not pull too hard on the nerve. You install the implant. Then you place back, then you place back the nerve. You cover it with a collagenous tissue. Then you place back the bone. When you reduce it, in most cases, it's much better that you just place PRF membranes and you just remove the bone, because what you have to avoid is, of course, when replacing the bone and you exert pressure, then you have a secondary anesthesia due to the fact that you just pressed onto the nerve. So mostly you're going just to leave the bone alone and place some PRF membranes. So now I'm really getting to an end. And of course, if there are some additional questions to this case, we can answer it then later on in the discussion section. So I want to come to a general summary of macroscopic, microscopic, and clinical effects of piezodome surgery in just 3 take-home messages. Piezodome surgery preserves and stimulates the undisturbed action of endosteum and periosteum by least traumaticity in soft tissues and by the cavitation effect that generates a much faster vascularization and a boost to the osteoblast activity. Second, piezodome surgery initiates bone healing with the first cut by ultrasonic cavitational stimulation of soft and hard tissue healing. And last but not least, very important for the clinician's office, piezodome surgery leads to more than 50% less patient morbidity. So I don't make a comparison, dear Ashish, but I just want to ask you, if you are in the state to be a patient yourself in some other fields of medicine, and you have to undergo abdominal surgery, what would you prefer? A surgery like this, the old traditional way, or a surgery like this, old traditional way? I heard about certain high-class oral surgeons, maxillofacial surgeons, scientists that underwent something like this on a birthday, and the 2 days after they are already working in the OR again. I mean, this is only possible if you do surgeries minimal invasive. As a discussion and conclusion, piezodome surgery significantly enhances precision, automaticity, and preservation of critical soft tissues formation, etc., etc. Just to give you an idea how you could start your training already if you're not already in the state of being able to serve patients and to work on patients. Just if you get hold on a piezodome, take a raw egg, preferably with a brown shell, because there you can see much better, and then try to do what a periodontologist from St. Petersburg some 10 years ago did when he had a piezodome in his hands for the first time in his life, because he was able to peel off the shell of a raw egg entirely without causing any rupture or any damage to the eggshell membrane. So here is the result. This was the task he should have done, creating a lateral window, simulating a sinus lift procedure. This is what he achieved after 15 minutes.
Angelo, you have to unmute yourself, Angelo, please.
Okay. So this is then the nice guy, Professor Dr. Peter Raschak from St. Petersburg, proudly presenting his de-shelled egg without any perforation. So, and just to give you also an idea about our research group, the TKW research group, that's me, that's Professor Andreas Kurik from Germany, Professor Marcel Wainwright from Spain, Sevilla. And just imagine if your task would be to cut in your initials into bone, like we did with the TKW research group. This is only possible with piezotomes and never ever with rotary instruments. And if we are speaking about how we should act ethically as oral surgeons, is it still legal to destroy bone, to heal bone, speaking about doing autologous bone block grafting, devastating bone with rotary instruments? No, not in implantology surgery of the 21st century. And this is just to give you an idea, so you're kindly invited. Hopefully we will start next week again with our practical trainings at some Asian universities directly on the patients and human cadaver courses at the University in Innsbruck in Austria, but still we do not have dates for next year. So I kindly thank you for your attention, and today I was quite on time. I'm proud of myself. And what you can see in the last slide, that's the internet connection for our homepage, http://www.India Alpha Uniform Sierra India.org is our homepage, and you're free to access it. That means you just type in the homepage address and you're free to use this, no registration necessary. And you can see all these lectures, PowerPoint presentations, and all these our educational videos. I thank you very, very much for your attention, and I hand back to Professor Ashish Kakar.
Thank you, Angelo. This was absolutely amazing. And, you know, if you allow me, I will share a couple of my, okay, if you can.
Yes, please.
Yeah. So whenever I show my presentation on the ridge plate, I always show you, and the boys behind, you know, you can see some of the good times we had. And I mean, just a couple of cases over here, just to show how thin the ridge was. And, you know, only with piezo, it is possible to split a 3 millimeter, 2 millimeter, or even a 1 millimeter ridge. You've done enough studies to show that. This is just showing the CS2. And, you know, see the precision on the cut, which is there. And then the vertical cuts, mobilize. And over here, we were comparing, you know, two different graft materials. Here's a xenograft with a membrane versus a synthetic graft. And just look at what we see post-operatively. It is absolutely amazing to see. And, you know, the implant insertion is right where you want it. And in about 3 to 4 months' time, you can get from here to here, still have enough bone all around the implant and a stable situation, even in cases like this over here, where you have such old extractions. And this is all a part of our clinical study, which we have now submitted to Journal Oral Surgery, and hopefully we should get the acceptance in the due course of time. And this is just using the synthetic graft over here, and then just placing our implant and then getting a very high initial stability, even in a grafted area, as you can see over here. So my take on On piezo surgery, yes, I think it's very conservative. It's highly effective, pain-free, relatively bloodless. You're not destroying bone to harvest bone, where you're just using very fine instrumentation and with keyhole access, as you showed, to get some amazing results. I think there are some other questions which are already being posted. Uh, there's a lot of thank yous. But any specific trick, I mean, with the use of tips, because I know people tend to get impatient with the surgery, and then they break the tips or they generate too much heat. So, we can do a lot of lectures, a lot of sessions uh, virtually, but unless people get a feel of what the instrument is like and how effective is the cutting and how much pressure to apply, how much force to apply, because you get a sense of feedback from the bone as to how much you can apply and how much can you push this whole armamentarium to achieve the results. Maybe a couple of words on that.
Well, maybe your students are in one of the best positions they could ever be. They have one of the most advanced piezotone surgery professionals in their own dental school. So for them, it's not the question because you will teach them. Actually, I would strongly advise if they have not the honor and they have not the chance to have you as a teacher, as your personal guide, because we are hand workers and you have to do it on your own. That means you have to use it. And I really hope that we will be able very soon, or let's say next year, to have workshops again directly with the device on sheep heads, on cow ribs, or no, sorry, no cow ribs in India, on sheep ribs or whatsoever. You have to do it, but you can train yourself simply by maybe if you have a friend who already has a piezotone, you take a piece of bone and you start cutting. And maybe you can also try then again to do the same with rotary instruments, and then you will learn the difference. It takes you approximately 1 or 2 hours using all the different type of tips, first reading the leaflet, how the tip is supposed to be used, and then check what happens if you are working on very hard cortical bone. If you press too much, you will see the device will stop to work. If you are exerting too much force, you are blocking the oscillations. If you reduce the rinsing, you will see that suddenly the bone is getting black. That means you're creating heat because you don't have sufficient rinsing. And if you press too much on the bone, even if the oscillation is not stopped, you will see a decrease in the cutting efficiency. This is how you can train yourself to find out the right balance between what is the amount of pressure to use. Actually, I always say you are the conductor of the symphony orchestra of bone surgery, because the conductor only guides the orchestra. The orchestra is the piezotome. So you just tell the piezotome, please cut here, and the piezotome will do the job. I can tell you that the optimum pressure will be 500 grams on the handpiece, but whoever has the experience to transfer a number of 500 grams on the handpiece into the actual work. This you have to train. And if you get to the more diligent surgical procedures, just take raw eggs. We do this the same in the workshops. We take raw eggs, and maybe the first one you have a perforation, the second one you have a perforation, but maybe after the third one, you will be able to do exactly the same what Dr. Peter Raschak from St. Petersburg did on his first attempt. And to tell you the truth, I was not able to do it on the first, but only on the second attempt. Just peel off the entire shell of a raw egg without perforating the egg membrane. This is how we should always approach our job. We have to do it. If you have a new type of implant, you cannot transfer the movements and the feeling of the old implant system to the new implant system, because maybe the new implant system has a more aggressive threading with higher primary stability, but you need to relearn how does it feel. Speak with the bone. Peter Fairbairn always says this, speak with the bone. And this is how you also have to speak with the piezotome, and it will tell you the way you treat me now is perfect.
Thank you. Those were very appropriate comments for the use of the surgery, because the instrument will just follow your command as long as you know what commands to give. So that's important. So for the benefit of all the people who are attending, as the travel restrictions will open, hopefully will open in the near future, we do plan to have workshops, and we do plan to have Angelo in our center. Hopefully, whenever he's traveling to Far East, he can just make a pit stop. We can do some workshops together, and it's going to be a lot of fun time to do that, because he's the master. I mean, I'm not as experienced as him. However, we work together, and with his experience, we can definitely benefit a lot. Thank you everyone for attending this evening's session. I'll hand it over back to Dr. Sucheta, where she can do the closing remarks. And I see Dr. Arundeep is there as well too, and Dr. Pankaj to make the closing remarks on this evening's session.
Thank you, sir. Thanks a lot. On behalf of Manavratna Center for Dental Excellence, I pay my gratitude, and marvelous. It was a great learning experience from Professor Angelo. And I really thank Dr. Ashish for getting him here for us. I think it's an eye opener for all of us. And going ahead, by getting him to our institute will be a great opportunity to learn from the master clinician himself. Sir, again, I thank you, Professor Angelo. I also thank Professor Ashish for all the wonderful efforts being done for the Manavratna universe. I would request Principal Dr. Arundeep to give his closing remarks.
Yeah, hi. Thank you, Angelo. It was really, I must say, I'm more amazed than I was last time. And it's really awed by the level of your dentistry. I would say it's like, evidence-based magic. So fantastic. We're really looking forward to have you in our campus. And great work, Team MRCD, Dr. Ashish, as usual, as using all his contacts to propagate and teach our students what is happening new and what is the latest in dentistry. Thank you, Angelo. Thank you very much. Really looking forward to see you in our campus.
Thank you so much, and heartily greetings to India.
Dr. Sucheta, closing comments, and thank you for organizing as usual. Everything was on time, everything was great, no hiccups, and the storm didn't hit too, so that's good news.
Yeah.
Thank you so much, sir. Thank you so much. It was definitely a great learning. And I as always say, Ashish sir is the best thing that could happen to us. And thank you. Looking forward to many more lectures. Thank you so much. And on behalf of Manavratna Center for Dental Excellence, I would thank each and every one, all my colleagues and all my HODs from different departments for joining us today, and have a great weekend. Thank you, everyone.
Okay, thank you. Good night, everybody. Enjoy.
Good night.
Right. Take care.
Good night. Bye-bye.
Thank
Bye.